My name is Michael Battelle, and I'm the president and founder of the Fatty Liver Alliance. Today, I want to welcome two incredible guests and a brand new topic to discuss. How great would it be if we could identify patients who are most at risk for advanced liver disease much earlier than we could have in the past? Dr. Mark Swain, hepatologist and professor of medicine from the University of Calgary in Alberta, Canada, and Dr. Tim Jobson, gastroenterologist, medical director, and chief investigator for the Somerset Liver Improvement Project in the UK, are both with me today. Tim, what do you see as the biggest challenges we face identifying patients who are most at risk of advanced liver disease?
So, this is a major topic for chronic liver disease for everybody who's involved in this field. And the key challenge, obviously, is that these patients present late. They present with advanced disease. They present with cirrhosis, or very commonly in our practice with decompensated cirrhosis. So the disease is so advanced, there's very little that we can do. If they're not a transplant candidate, often this is a pre-terminal event, and very little that we can offer them in healthcare. So we need to identify these patients much, much earlier in their disease course, because there are treatments for pretty much every chronic liver disease out there. Whether that's lifestyle intervention, whether that's specific drugs, whatever it is, whether it's antivirals or anti-inflammatories, there are treatments available, and we need to identify people earlier. So I guess one of the questions is, why aren't we? We sort of know what to do. We know that patients with abnormal liver tests shouldn't be ignored, or people with lifestyle risk factors, particularly for fatty liver, or who have other medical conditions associated with fatty liver, like type 2 diabetes. These people need to be screened, if you like, but tested properly, and those tested acted on. So I guess where I was coming from with this work is, we keep seeing people in the clinic and we just look at their blood tests going back 10, 15 years, and it's all there. It's all there to see already. Where I live and where I work in the UK, we have a pretty stable rural population. We've got the same database of blood tests going back 15, 20 years for these patients, and we can just see, hang on, we should have known about this patient earlier. So that's the challenge that came out of the clinic room for us.
Okay, that's great. Thank you, Tim. And Mark, in Canada, what would you say? You agree that there's an issue in identifying that early identification?
I think it's the same problem around the world, really, uh, and this concept of seeing people that come to you and in Canada they're being referred to, and then you look back and you see these tests that are abnormal. It's obvious there was something going on in their liver for a long time. I think part of the problem too is as specialists, we're certainly we're part of the long-term problem, in that is that individuals used to be referred to us. We didn't have a good, or we had no non-invasive tests of examining these people's livers. So we often would see these people, and if it turned out we ruled out the other cause of liver disease, which at least was a big step forward because we ruled those out. But if they were left with fatty liver disease, we often sent them back to the family doctor, recommending things like lifestyle, but actually often saying that this is a benign, felt to be a benign process, non-progressive. And so over the years, we've actually created an issue where there's a large belief that of the people that understand and know what fatty liver disease is, and at a primary care level, they often go, "Oh, that's okay. It's just benign. Don't worry." And we know now that's not the case for everyone, and so we need to have a structure in place that we can pull those people out that have a liver issue. Obviously, people with fatty liver disease have a metabolic issue broadly, but there's only a smaller subgroup that have significant liver issues, and that we need to be able to identify them and stream them into the right stream so that they can be managed from a liver point of view, as well as their other metabolic comorbidities.
Like thank you, Mark. And we recognize, the rate's 25%. Is it 40%? I don't know, but there's obviously a lot of people who have fatty liver disease. There's pharmacological solutions that are on the horizon. They're coming, and waiting until the last second when they're actually approved and then worrying about the problem is probably not the best approach. So you're both right. We need to really, this is the right time for us to be doing this.
And we have, I mean, we don't have approved pharmaceuticals yet, but we actually, it's interesting. Certainly, I'd be interested to hear what's happening in the UK, but here in Canada, people are using more and more of things that they can access to help these patients, even if they're not diabetic. GLP-1 agonists are becoming things that are very commonly being used, even though they're not approved for weight loss in Canada. They are being used, and it's quite striking to see how that has changed in the last 6 months. Even it's really quite mind-boggling how primary care is starting to see that we need to do what we can do to help people. And one of the things we can do is some of these drugs that are available, certainly if people have the means or ability to access them, is that they are quite good at helping people lose weight, which is a big cornerstone of managing fatty liver disease.
Tim?
Yeah, absolutely. And I think maybe we're not quite there in terms of recognition and treatment in primary care. And I think absolutely what you're saying has played out. It's a benign condition, it's purely lifestyle. And interestingly, I'm now working in a centre where we do have bariatric surgery, which will have a huge impact on people with type 2 diabetes. But the rest just get a minute or two with a primary care physician who says, eat less, move more, and off you go. And I think people aren't taking it seriously, and that's why we're seeing this cumulative liver damage over many years with people where their condition has not been addressed at all.
And Tim, my sense is too that I hear primary care physicians are really busy with lots of different things, not only a lot of patients these days, but a lot of things on their plate. And so maybe the thing like what you're working on right now is a more effective way to identify patients that they don't have to actually go back and look for, right?
Yeah, absolutely. So I sit with a patient in the clinic and you'll see a string of abnormal tests going back 10 years. And the patients have asked me repeatedly, why wasn't this acted on back then, or that one, or that one? And of course, we know part of the answer is on any one day, it's not dangerous. It's not a condition that needs immediate and urgent treatment. And so it just gets left. And you're right, they go back to their physician a few months later, have another set of blood tests, and sure, the same thing's there. And the physician goes, well, it's stable, or they don't even look back. And so that's why you get this, when you look back, this real sequence of abnormalities that's never actually addressed.
Sorry, Mark, did you want to say something?
I think that's the issue over and over and over again, and that I think what Tim is doing, I think what people are around the world are trying to do is how can we actually look at these people in a way that removes out that human thing where they have to evaluate those tests, or provide them with a tool that allows them to very simply assess if these people have liver disease or not, and so that they can access care as opposed to just repeating the tests over. I mean, we also look back and you'll see the people may have fatty liver on ultrasound that dates back 15 years, and they're getting ultrasounds done every year, and sure enough, the fatty liver is still there. But there's nothing like it's not just a management issue with regards to the individual with fatty liver disease. It's also at the cost of the healthcare system is astronomical, reading these tests over and over and over again, or doing them over and over again without having any real plan in place to actually how you're going to act on them. So it's doing a test without acting, and so it's to facilitate the action. I think is really the key, is to get that switch to go on, whether that person then is referred or not, and based on objective evidence. I think
That's a big part of it, right? Because you can't, millions and millions and millions of people can't go to the specialist. So we're definitely going to have some kind of algorithm referral pattern of some kind. I wanted to talk, if I could, a little bit, if you can both comment on, like, so what? So people want to know, so I've had it, many people have had it for many years, and it's like, it hasn't really changed my life because I got other things to worry about, right? So what is the advantage of earlier identification for patients? Tim?
So absolutely. I mean, I think our early experience with our project, where we've actually, and we're already calling patients in, so we're reversing the referral process. We're calling patients, we're kind of letting the primary care physician know that we've identified a patient. Unless they have any objections, they're going to come to us. So we're doing that already. And interestingly, I think those patients have a very different perspective on their condition. Firstly, the feedback we've got is incredibly positive. So patients are saying, yeah, I'm really glad you did this. But also, it's a kind of wake-up call to the patient, particularly when it comes to lifestyle and so on. So that approach of seeking out the right patients and engaging with them in that way, I think triggers a different response, rather than being told by your GP yet again, look, you just got to be more healthy. And certainly that's what we've observed.
And of course, the problem with being told you need to be more healthy is that we all know we need to be more healthy. There's very few people that get up in the morning, gosh, I'm as healthy as I could possibly be. And so
Yeah.
it becomes, when you get told it over and over again, and we all kind of recognize it in our mind, we have a filter for everything, and we just filter that out, and so it doesn't create any action, and unfortunately, it just becomes almost like a ritualistic thing within the family diet. You got to be healthier, and then of course what happens is that if, say, as people are gaining weight, they start to get arthritis and issues with, so their mobility is affected, so it becomes a self-fulfilling prophecy that they really can't engage in physical activity like they used to or whatever, and it just gets worse and worse, and it becomes very, very challenging for them, because that it's a negative reinforcer over and over and over again.
Well, Tim, can you explain to us a little bit about why the program that you're working on is different from what's currently out there?
Sure. So, I mean, I think a lot of people are trying to identify patients, in time. There's quite a lot of work in that field. What is different, I think, about what we're doing is we're recognizing the value of all the data that's already sitting there. So this isn't reactive to an individual blood test that's come in. We're not waiting for a referral. We're saying there's a huge amount of data sitting in our systems, and all we need to do is interrogate that in the right way, and we can risk stratify our population. And I think the risk stratification bit is really important because, as you said earlier, we can't have everybody coming to a liver clinic. It doesn't work like that. So we need to target our resources as well at the right people. And our clinical systems, probably universally, probably worldwide, if you know who the patient is, you can get a lot of data about them. So I can key your details in, and I can pull up your bloods, your x-ray, everything there. But what we can't do at the moment very easily is say, okay, show me all the patients with this particular pattern, or all the patients who meet that risk threshold, who are starting to show perhaps signs of advanced liver disease, whatever it is you're looking for. And so literally our approach is different. We're taking that huge stack of data, curating it in a different way, and just priming it for those questions. And at the moment, we're priming it for liver disease specific and chronic liver disease specific questions. But you can, I think you said right at the beginning, we could apply this kind of approach to all sorts of things and go and find people who need prevention or early treatment much earlier on, and not wait for them to be picked up. And I think also the history of screening programs, it's checkered in liver world. Obviously, cardiovascular screening, cancer screening, it's much more embedded, but we've just not got traction with screening, I think, in the vast majority of what we're doing in the liver world. I don't, again, what it's like in North America. Specifically, we screen high-risk populations for hepatitis B, hepatitis C, and so on, but that's pretty much where it ends. So if we're not going to have a screening program, and we've got this massive stack of data, let's go and interrogate it and find what we can and risk stratify our population.
Mark, this is actually, sorry, I don't want to interrupt you, but it's funny because as Tim talks, I'm thinking about you and how many times you've told me that you don't use the word screening, use case finding. And really, this program is about case finding specifically, right?
And a big and which is exactly, I think, what Tim was just describing. It's the problem when you, because of this checkered history of screening, but also because there's so many people that want their screening programs for their disease, that it becomes an overwhelming thing, and it's mandated. A screening program, by definition, becomes mandated, at least in Canada. And so, say for breast cancer screening or whatever, then there's a ritualistic thing you go through, which is very expensive, and it's very time consuming for family physicians and all the structures that have to be built around it. And so there's not a lot of receptivity, certainly in Canada, for primary care about screening programs. Case finding, they're quite interested in, because the way when I'm talking to primary care, it's really about empowering that primary care physician to care better for their groups of patients that they have under their care. And so when you have a certain thing, and say with Tim, through an EMR where you can flag someone as being at risk, most family doctors are really like having that done, because they're very busy. They don't have time to sort of look through all this data. Suddenly a flag comes up and says, have you thought about screening this person for non-alcoholic fatty liver disease or whatever disease? it makes a huge difference. And so I think you can do these kinds of things. Of course, in Calgary, we do it's a little bit different, but it just because we don't have we have multiple primary care providers with different EMR systems, and so they have to you'd have to do it for each one of those becomes a bit more challenging. And so we just need to wait until they're more integrated, and they're all becoming integrated over time because the bigger companies are buying the smaller companies. And so I think hopefully we'll get more like the NHS at some point, where we can really implement these across a universal system, like an Epic type system that's everywhere, where people can then we can use the same algorithm or the same IT support, I guess, to make sure that that's in that EMR and doing what it's supposed to do.
Thanks, Mark. Tim, so you came up, I don't know if it was you who came up, but maybe you can even tell us how you came up with the name. So Hepatocyte, SIGHT, is kind of a cool name to, when you're talking about finding cases of advanced liver disease. So how is that program going? Like, how many patients have been enrolled, or how many clinics, or just to get an idea of the size of that program would be kind of good to know.
So where we are at the moment, we doing this within our local population in Somerset. So that's a kind of integrated care system for 500,000 people. Interestingly, although that's not a completely stable population, some people have moved away. We've got around about 500,000 people in our database, which suggests that most people, there'll be some people who've never had a blood test in the last 15, 20 years, but most of the adult population have had a blood test at some point, and they're in the system. So that's the size of the data set we're looking at. We build a system in terms of calling patients with clear markers of chronic liver disease. This is a very early stage. So we've literally sent out about 20 requests to people to come to clinic. And this is just trying the process at the moment for us. So we're learning as we go, trying the process, come and see us. We found that you might be at risk of one or other chronic liver disease conditions. And we're very cautious. Where does that go in terms of scale? I think we'd probably all recognize several hundreds of patients out there who are probably at high risk. And we can use our system to find those now. But we're just not primed, ready to have a few extra 100 patients coming to clinic right now. So we're working on that part of the program. But that's the order of magnitude. And we want to find high-risk fatty liver disease, but also other chronic liver disease in there as well.
Well, I mean, to be clear, it's in the early stages, but 20 people who wouldn't have known that they had advanced liver disease, you could very well have saved their life, right? So, and those, I mean, people say even one patient's life matters, right? So, you get to 20, and then this is a start. And if it's something that works really well, then it'll be a lot more of this happening. What did the patients that you talked to actually say, like in general?
So today, the ones that have come to clinic, universally positive. They really have been. We were nervous to an extent. I think the healthcare organizations were a little bit nervous because, is this about misdiagnosis in some way? And my feeling isn't about misdiagnosis. This is about just being more proactive in making a diagnosis. We know that minor abnormalities are not acted on, so we're being much more proactive. The patient's response to this, when we first spoke to patients before we did this, there was a little bit of kind of questioning. You mean you're not doing this double checking already? Surely that's what you guys do. You check through our blood test, retrospectively. Well, we don't. And a lot of that is around data. So access to data is a huge problem sometimes with these kind of projects and programs. Patients, when they come to us now, have all said, once I've explained why they're in clinic, they haven't been referred, they don't know why they're there. Once I've explained that, they've all said, well, thank you for doing this. Thank you for doing this work. What does it mean for me? And that bit about how do I need to be more healthy comes out almost from them rather than from the physician in the clinic. That's really very different experience in clinic, in my opinion. We haven't had pushback as yet. We haven't had people saying, what on earth are you doing? Scouring around through all this data and looking at my records of my past stuff. That is obviously a risk with this sort of project, but I think it's the right thing to do for these patients. And so far it's been good.
And that raises a very good point. Is this whole thing about privacy and it's a big issue certainly here. So in Alberta, part of Canada that I'm in, it's an integrated healthcare system. So everyone has one unique healthcare number, and all of the lab, whether it's their administrative data or their laboratory data, their pathology data, it's all in one thing. It can all be searched or whatever. So it's very powerful from a of looking at a large database and saying, okay, these are the things we should be looking for. But when you go into EMRs and you're starting to talk to the family doctors, it's really, it's them that need to be looking at the data. We can't look at an individual's data and say, that person over there and who lives over there, we need to go and get them because they're at risk of liver disease. That has to come because that's privacy issues, right? And so they're always coming up against things where, common good, we're trying to do the right thing, but in the end, the privacy of that person's own healthcare data has to be protected, and so and I'm sure Tim deals with that on a daily basis. But it's becoming stricter, and so it's even harder to do these things that are really empowering physicians to actually not just look at data, not have that be asked the question, well, haven't you been looking at my liver test for the last 5 years, and that they've been abnormal for 5 years. Why hasn't something been done? Which I think Tim was just describing, is because everyone's quite happy when someone says, oh, because the first thing it says, well, why wasn't someone doing something about this? Why has this been going on? So there's a frustration at the patient level about why people aren't acting on it, and so we need to create ways that people are empowered to act on it. I think is what Tim is really doing, and everyone's trying to do it. But I think, I mean, many people are trying to do it, but I think that we need people that are very smart, that understand IT and understand the healthcare system, which is the numbers drop quite quickly when you're getting into that sort of group. And then work with people in a way to use the computer techniques that we have to be able to pull that data out and provide it in a way to family doctors that it's easy for them to use to help find these patients at risk for whatever disease, not just liver disease.
I think we're looking at the future. Tim, we're going to definitely have to have you back, have this discussion again at whatever interval you think you're ready. If it's a year from now, maybe. And I want to thank both you and Mark for joining me today, and the Fatty Liver Alliance. And we'll talk to you again soon. Thank you so much.
Thanks for having us.